Good morning, everybody. It's a privilege and an honor to welcome you all to Ganga Ram Hospital. And this is our department's function. Congratulations. And I'm very, very proud of the team which has done it, Dr. Anmol and Dr. Tarun and others. And thank you all delegates for sparing time for us. So we heard a lot of theory. I believe in surgery, practice and practical approach is more important. When the discussions were happening about 65%, 40%, 30%, I was remembering a quote by American president who was a scientist also, Franklin. He said, if a person has a foot on a hot stove and another foot on an ice cube, statistically and scientifically he should be comfortable. So I think in surgery, the statistic and 40%, because every percent is 100%. So thank you very much, Tarun, and greetings from our hospital. This is the view from our new block. You can see we are in a good air quality index area. So thank you again for coming. This is our department. I am junior to Dr. Sarangi, Dr. Malik, and Dr. Vijay Roda. It is only the policy that made me the chairman. So I remain grateful to all my seniors for handing over the torch to me. Thank you, sirs. I'll be speaking not from theory, you already know, but from my practical experience, and they have stood well with me in my practice. Patients do come back, bringing other patients. And all facts are based upon anatomy and physiology. Big Four, Kiley, Welch, Halsted, Osler, they established in Baltimore, John Hopkins, they used to fight like we always do with our colleagues. So Halsted will always fight with Osler and tell Osler, we surgeons are better physicians. So he said surgeon is a physician who can also operate. So bottom line is, if you understand the anatomy and function of that anatomy and you address the pathology as a surgeon, you will do well. And Dr. Singla, Dr. Kamal, Dr. Rajdeep, Dr. Seema gave us a good insight into anatomy and physiology, and it is now up to us whether to destroy the anatomy irrespective of function or not. So we have to concentrate, focus on what is patient looking for. Informed consent, we say, but what is it? You minimize the expectation outcome gap. If you do that, you will do well. Before putting a knife, we must remember that any bad outcome is not only a scar on the body of the patient, it's a scar on the surgeon's psychology also. None of us will feel good if our patient is suffering. So keep your knife very conserved. My talk is principles of fistula surgery. So as since morning you're listening, you have to know the anatomy so that you can define the anatomy of pathology in that particular person. Then second thing, before you convert any epithelialized tract to an acute wound, because in fistula, the aim is to convert chronic inflammation to acute inflammation. Chronic inflammation, as Dr. Ratna emphasized, it is an epithelialized tract. So you destroy, ablate, or remove this epithelialized tract and create a fresh wound which will heal by primary or secondary intention as an acute wound. For that, it is necessary identify, locate the source of sepsis or a cavity as seen on MRI or clinical examination. Must drain that before you do anything. And following that, you may think of eradicating the tract so that you prevent recurrence. And doing all this, if you know your anatomy well and the functional importance of that anatomy, the focus in our mind should be that there is no compromise with the sphincter complex so that patient maintains full continence. So again, drainage before you do anything, ablation of tract, ablation of granulation, as you said in the last, that MRI should be done because in intersphincteric abscesses sometimes may go cranially unless you scoop the granulation out. A surgeon is supposed to look cranially and scoop the granulation out. So that cannot be justification for MRI. MRI has a lot of other justifications. There is no harm in doing it. And respect the sphincters. So what are the principles? So our interaction with patients starts from history. So we have to examine and talk to our patient and see that we are dealing with fistula. So as we were discussing, we have to have a differential diagnosis in our mind, whether it is a pilonidal sinus or a folliculitis or a hidradenitis suppurativa, or in females a Bartholin gland. So you have to have some red flag signs for them. So if Has the person has similar lesions anywhere else in the body, especially armpits or the groins? Maybe we are dealing with hidradenitis suppurativa. Is there an infected sebaceous cyst or some inclusion cyst? So ask the patient, did you have a small lump, lesion, mole, wart, anything in this area which was standing there or sitting there for many years? And were there any anal symptoms? I have hardly come across a fistula patient who will not have any problem related to defecation. So if you go in history, they will always say they have had that irritation, burning or discomfort at back passage during defecation or post defecation 6 months back or a year back. So if there are no anal or defecation syndrome, probably we are not dealing with a fistula. So again, history should be specific. The principles of surgery will depend that you have ruled out all possible differential diagnosis and all complex fistulas. As Dr. Rajdeep said, now the classification is only simple and complex fistula. All complex fistula need MRI. Simple intersphincteric less than 30% of sphincter, you may do MRI according to affordability or institution like Ganga Ram, but that's not an academic approach. So you rule out in history any symptom suggestive of inflammatory bowel disease. There is a Rome 3 criteria for that. That's not the topic of today's discussion. Has the patient has anything to suggest diverticulitis, any previous history of radiations or malignancies, tuberculosis, or possibility for ART. So what are the red flags? Fistula patient will not have abdominal pain. IBD might have. Fistula patients, unless secondary to chronic illness, will not have weight loss. Fistula patients will not have change in bowel habits. They may have bad bowel habits, but no change in bowel habits. So these three things in history should be there. After you have done history taking, then you do examination. And as been discussed repeatedly, Goodsell and Miles gave us something 125 years back, which still holds true. They said there are 5 essentials to treat fistula well. One is locate the internal opening, and now our latest understanding is coming that if you circumcise internal opening, clean the intersphincteric space, leave everything else, cavities and external fistular tract, fistula will not come back. I have no large data, but I have practiced this in some of my difficult patients, that is circumcise the internal opening, excise it, open the intersphincteric space, scoop or curate that out, send it for histopathology and gene expert or tubercular culture, which I do regularly, and I haven't seen recurrence, but to define recurrence you have to follow the patient for many years, 5 years, but for 1 year I can say with this simple approach. So Goodsell said locate the internal opening. A fistula will never get cured unless you have ablated the internal opening. Locate the external opening, which will lie somewhere close to the previous surgery of drainage or area of pain where patient said spontaneously ruptured. Then you palpate the course of primary tract. As Dr. Ratna said, in my patients I will say in more than 2/3 of patients, even if it is a high fistula, a good digital rectal examination, your finger is your biological probe. You can palpate the induration even if it is transsphincteric. So you have to just do it bimanually. Rule out any secondary extensions. That is where MRI will help us. Endorectal ultrasound is subjective. It's not objective as MRI. Plus, if you instill hydrogen peroxide in anorectal ultrasound, you might see the state of sphincters better than MRI. And also rule out other conditions before we proceed for managing fistula. Do not probe. Now, classically, it was thought that we can probe in OPD, but that's not giving respect to the patient. We must examine from groin to the perineum and even beyond. You heard in the morning how Scarpa's fascia continues as Coley's fascia, continues as Darter's fascia, continues as the fascia on the levator or superior and inferior levator fascia, and finally into the fascia lunata. We'll coming to that. As I said, external opening lies at the site of drainage or rupture. External opening sometimes may be doubtful in dark-skinned people, acanthosis nigricans, or some skin conditions. So it might appear as a sinus opening, which is discharging or not. There might be granulation tissue on top of it. Or when you do a digital rectal examination and squeeze it bimanually, you may see the discharge, which may be pus or bloody. Then, as I said, if you do a bidigital palpation of anal canal, in most of the cases, unless it is supralevator, we can make out that yes, this inflammation is extending up to certain area. Then you assess, I call it a dynamic digital rectal examination, which I published and which has become part of evaluation for ODS, that you do a digital rectal examination, ask the patient to hold stool. If he squeezes your finger, then sphincters are well. If you ask the patient to pass stools, he relaxes your finger, then it is no dyssynergia, as well as tone is good. Then you examine sites of previous surgical intervention. Good cell rule, everybody know, anterior fistulas are usually straight and posterior are basically not so simple. This is a diagram which I made and I follow in my practice. It's been taught in the morning. So this is anal canal, internal sphincter, 3 parts of external sphincter, levator ani, fascia of levator ani. Above that will be colles, tartus, and then scarpa finally. This is ischial tuberosity and this is obturator internus, fascia of obturator internus, and this is Alcock's canal. Alcock also described what is known as luneta fascia because it's lunar, semi-lunar. Now this is a dense fibrotic fascia. Once ischiorectal abscess happens and if it breaks down, there are 4 areas of weakness which will define how the pus tracks, and this is what Dr. Kamal and Dr. Singla told us in the morning, so I won't repeat it. So once you have done history, clinical examination, preoperative localization may be helped, as you heard Dr. Seema Sood, by MRI, endoanal ultrasound, or finally we have to do examination under anesthesia. I always write it on my OPD paper. I will not go by MRI findings, but I will get MRI done. I will believe my digital examination and I would believe what I see on the table. I will not try to see my belief based on MRI, but I will certainly get it done. So treat what you see on the table. Don't treat what you believe from the imaging. Imaging is a good guide, but there are always some differences in clinical assessment and image. So examination under anesthesia, which can be done by us in many other ways. I follow hydrogen peroxide. Literature says milk. I don't know why. People use methylene blue. I also use, but very diluted. So this is sometimes when internal opening cannot be localized, it is fibrotic. You can pull the external opening. You see a dimple or a tug at the mucosa or anorectal junction. Then that is the point. And I use number 1 proline in such cases. You can see. And if number 1 proline can go through that opening, then I slide or track my railroading of that over the proline. Now this is a video, a simple one, because I recorded it 3 days back only because the talk was given and then I thought I should record these things. Normally we don't record. So hydrogen peroxide from installation from one of the external openings shows that both the openings are communicating but nothing is seen inside. So we were surprised. So this is a case of a branching fistula. The branches are at probably acute angle. But when we put hydrogen peroxide from this perianal closer opening, it comes out both internally as externally, you can see. So peroperative demonstration this way is, I think, standard in most of our hands and should be utilized. Then we put diluted methylene blue mixed with hydrogen peroxide or alone, and to confirm, also to stain the tract, but we should not use concentrated methylene blue because that can extravasate and complicate our dissection or enlarge our wound. So this is peroperative localization of internal opening. In majority of patients, always is always wrong, never is never right in surgery. That is why I'm saying this, but I have been supported by this technique always, but I may be wrong someday. So I learned all the new tools. I was lucky to be first Indian taught by masters because when I started presenting my cholecystectomy and hernia things without energy, so I became friends with the pioneers. This is Arun who devised lift, and they have all gone to our holy places with me. But why am I showing this picture? This is Monroe, the WAFT person, and Wexner for Wexner classification of abscess and fistula, because I think a fool with a tool is still a fool. So I remain a fool with new tools. Clinical assessment, history, and looking at table is my primary guide. However, we should not shy away from MRI and endoanal ultrasound. Now new modalities are coming up with peroperative ICG delineation, peroperative endo ultrasound, and even fistuloscope, which you know as WAFT. I say remember the 5 English vowels A, E, I, O, U in any surgery. Assess the patient and access the area. Have all the equipment with you. Don't shout for equipments in between surgery. instill the dye or agent, and then start incising. Then you open and dissect the pathology. Go till you understand, stop where the understanding stops. Technology is like an hammer and nail. Maslow said it's a hammer cognitive bias. If all you have is a hammer, you treat everything as a nail. So that should not be the case for a surgeon. As I said, a fool with a tool will still remain a fool, like me. I wrote this editorial in 2008 in Surgical Endoscopy. I said the surgeon should be an imagination-driven engineer. He should be innovative, understand biology, understand physics, chemistry, engineering, everything. And you should imagine and believe what you see. Thank you so much. This is my honorary fellowship function of American Society, and this is our department. Thank you once again for all my seniors to bless me with the responsibility, and the team for organizing such a wonderful thing. Tarun makes us feel proud because he can organize things in a unique way. Thank you. Yes, sir.
Presented.
First, I enjoyed your talk. Second, do you think there's any advantage of doing this surgery in jackknife position? We all have been doing our surgeries in lithotomy position. Do you think there is some advantage of doing it?
Yeah, I think jackknife is better. I don't do it. Why I don't do it? Because it is time consuming, and the OT time is precious for us. If I was having multiple tables and dictating situation, I'll do in jackknife. Jackknife is ergonomically better for surgeon. You can shift your positions, you look better, and you prevent injuries to structures which are anterior, prostate, urethra in male, vagina in females, because you're looking directly at them. So jackknife is biologically and ergonomically for surgeon better. I don't use it because of the OT time constraints.
A compromise on that would be a lateral. If the external opening is below the lower half, the posterior, a lateral position is better access than lithotomy.
I won't comment upon that. There are 4 positions for doing digital rectal examination. It is our convenience, time, facilities, resources. But in surgery, I said 1 foot on the ice block, 1 foot on hot plate, and person cannot be comfortable. So we should not, surgeon should not compromise on his comfort at the cost of patient's outcome. Although we compromise for OT time and we don't do jackknife, but we have a colleague who uses only jackknife. Am I right, sir? And jackknife is ideal. If you have good time, OT time, jackknife is ideal for anorectum.
The surgeons should be basically comfortable.
Yeah, and you don't miss things like pilonidal, because we all of us get patients who have been treated as fistula or pilonidal sinus, or treated as pilonidal sinus or fistulas. Thank you very much.